Hello, this is Dr. Kim Ferguson. We're going to talk today about drugs affecting the respiratory system. Now, as an overview, we're going to talk today about bronchodilators, leukotriene modifiers, corticosteroids, oxygen, antihistamines, decongestants, and also cough preparations. Now, looking at the beta-2 agonists, beta-2 receptor agonists, we're going to talk about the short-acting beta agonist and the long-acting beta agonist. And so, one of the first things you need to know is which medication falls within each of these categories. Now, with a beta-2 receptor agonist, these agents are used for a lot of different age groups, from real small in the pediatric population to the elderly population. So it's truly a medication that is used across the lifespan. Now, it is used to treat reversible bronchial constriction caused by asthma, reactive airway disease, or COPD. And there's a lot of different forms and delivery systems that is used for these class of medications. Now, you really need to know the pharmacodynamics of this medication. Now, these bronchodilators act on the smooth muscle of the bronchial tree to reverse bronchial spasm, and by doing this, it decreases airway resistance and residual volume, and also increases vital capacity and airflow, so these are good things. The problem with, or drawback with the bronchodilators in regard to the pharmacodynamics is that you really wished, in a perfect world, that the beta-2 receptors would be only affected in the lungs, but the problem with these medicines, they also have some effects systemically on other body systems, such as the cardiac system, the central nervous system, and also skeletal muscles, and probably of these, cardiac is the most significant. And so some of these medications will have fewer adverse effects than others, and they also affect the beta-1 beta-1 activity. And so with these medications, when you're looking at these, look and see, is it mainly beta-2 with some minor beta-1, or is there significant beta-1? Because when you understand this, that kind of helps you as far as determining your drug selection and also anticipating some adverse drug reactions with these medications. And so some of these age groups you may want to avoid with certain medications because of this consideration. Now, with albuterol, it's a selective beta-2 agonist, and it does have some minor beta-1 activity. Now, it can increase heart rate by directly stimulating beta-2 receptors in the heart and by stimulating beta-2 receptors in vascular smooth muscle. Now, the effect on cardiac beta-2 receptors is of consequence only at high serum levels of albuterol, because it has a low affinity for these receptors, and there are fewer beta-2 receptors than beta-1 receptors in the heart. Stimulation of the beta-2 receptors in the vascular smooth muscle leads to vasodilation and a decrease in diastolic blood pressure, and you can also see a reflex increase in the heart. Now, as far as skeletal muscle, it causes the beta-2 receptor stimulation in skeletal muscle, and it can lead to tremors. Now, albuterol has fewer cardiac and CNS effects than some of the other beta agonists, and it's the drug of choice for first-line therapy. Levoalbuterol is similar to albuterol, where the S isomer from the racemic albuterol is removed, leaving the R isomer, and it has less adverse effects. Now, with salmeterol, it's more selective for beta-2 receptors than albuterol and has minor beta-1 activity. It's a long-acting inhaled bronchodilator with a half-life ranging from 10 hours to more than 40 hours. and it's more selective for beta 2 receptors than is albuterol, and it has minor beta 1 activity. Now, looking at beta 2 agonists, precautions and contraindications. Now, cardiac arrhythmias are associated with tachycardia or heart block caused by digitalis intoxication, angina, narrow angle glaucoma, and organic brain damage. And the organic brain damage is with epinephrine alpha also only, and shock during general anesthesia with halogenated agents. And these are contraindications to beta 2 agonist. Now, because of the agent's effects on the cardiovascular system, if you have a patient with hypertension, ischemic heart disease, coronary insufficiency, congestive heart failure, and a history of stroke or cardiac arrhythmias, you really have to watch these patients closely for adverse effects with administration of these bronchodilators. Now, with patients who have diabetes, there is a potential drug-induced hyperglycemia that may result in loss of diabetic control when using any of the beta 2 agonists, and so you have to consider insulin dosage may need to be increased. With patients with hyperthyroidism, adverse reactions can occur with the bronchodilators, and so you have to watch more closely and have a higher expectation for adverse drug reactions. Now, patients taking digoxin requires close monitoring when albuterol is started, because albuterol increases the volume of distribution for digoxin and can cause a 30% decrease in blood digoxin levels. Now, patients with a diagnosed or suspected pheocytochroma should avoid the beta-adrenergic antagonist because of severe hypertension that can also be seen, and it can be noted. Now, with your long-acting beta agonist, you really need to consider that there's a black box warning and the risk of salmeterol and also formoterol outweigh the benefits and should not be used singly with asthma for all ages, and so those do not need to be used for monotherapy. There's also a twofold increase in catastrophic events, and this is related to asthma intubations and death. Terbutaline, pregnancy category B, and so that's easy to remember. It is a category B and the rest are category C. With children, albuterol is safe, relatively safe in children, and salmeterol should not be used in children less than 4 years of age and never as monotherapy. And monotherapy means it's the only medication used. Also, with your older population, you might need to use lower doses of your bronchodilators. Now, with your beta agonists, you can see some adverse drug reactions. The good thing is these are usually transient, and so it doesn't always mean that you have to stop the medication. So you can just, a lot of times, if the side effects or adverse drug reactions are not severe, you can reduce the dose, and that a lot of times will help as far as the side effects, and then you can slowly increase the dose after the reaction to the optimal dosing has subsided. You can see supraventricular and ventricular atopic beats with inhalation, but the incidence is low. However, you can see tachycardia and palpitations in a small number of patients who use the symptomomimetic bronchodilators. You can also see CNS excitation effects with tremors, dizziness, shakiness, nervousness, and restlessness in some patients, and also headaches can be reported. Insomnia is rare, but patients can also, you can also see they can have a post-inhalation cough after using Indicterol. Salmeterol has a documented increased risk of exacerbation of severe asthma symptoms if the patient is deteriorating, and so to avoid this, none of your long-acting beta-2 agonists should be started in patients with acutely deteriorating asthma, and it's best used in combination with an inhaled steroid. And so that's something that you've got to remember in these patients. Drug interactions, because of the cardiovascular effects of the bronchodilators, you have to watch for drug interactions. Now, if any of these medications are prescribed with digoxin, you have to be really careful, and you have to monitor their electrocardiogram because of the risk which is increased with cardiac arrhythmia. Now, beta agonists used with beta adrenergic blocking agents, and this is also your eye drops or your eye preparations, may result in mutual inhibition of therapeutic effects. Also, tricyclic antidepressants in your MAOIs used can potentiate the effects of the bronchodilator on the vascular system. So you've got to also be careful with this. With clinical use, bronchodilators are used primarily in the treatment of bronchospasm, and it's used with asthma, bronchitis, and that's acute or chronic, and also COPD. Now that's typically what you'll see. The albuterol metered dose inhaler, and it's MDI, is 2 puffs every 4 to 6 hours, and I want you to know this information because it's a medication that's so widely used. So I need you to know this. You can also use it by nebulizer, and I want you to know the dose for this. And so your doses can be repeated if needed. The levoalbuterol can be provided by nebulizer every 6 to 8 hours. And also your salmeterol discus is 1 puff twice a day. With this, you do not need to use alone for persistent asthma, and you need to combine with an inhaled corticosteroid. Now, it's also used in exercise-induced bronchospasm, or EIB. Now, it's used to prevent exercise-induced bronchospasm, and so the dose for the albuterol MDI to prevent exercise-induced bronchospasm is 2 puffs every 15 minutes, and that's prior to exercise. And so patients, you have to make sure that you discuss with them it is prior to exercise because you're looking at prevention. I had a patient not too long ago that was had been prescribed beta agonist for exercise-induced bronchospasm by another provider. And so when I was asking them about this, they were saying they were taking it so many minutes afterwards. And so it needs to be before their exercise. And so education is key with these patients. Now there's different time frames with this, but with albuterol is sort of the gold standard with your beta agonist, and so you take it 2 puffs 15 minutes prior to exercise, and it gives you kind of some support of prevention for about 2 to 3 hours. Now the dose of salmeterol is 2 puffs 30 to 60 minutes prior to exercise, and it should prevent exercise-induced bronchospasm for 10 to 12 hours. And so there's a huge difference between the two. Also, your leukotriene modifiers taken daily may decrease exercise-induced bronchospasm symptoms in 50% of your patients, but your patient still needs to use albuterol before exercise, and so it's not a monotherapy. So make sure, I want you to know this information on this slide. Now, with the rational drug selection, it does not differentiate or recommend a specific short-acting beta-2 agonist for use in asthma according to the expert panel. And so when you are looking at prescribing any of the bronchodilator, you have to look at different factors, and a lot of it that you look at is the age of the patient and also cost. So um, the only short-acting bronchodilator that can be prescribed for children under age 4 are albuterol and metoprolol. And so that is something that you need to kind of understand. And levoalbuterol is labeled to be used in children older than age 4, and the guidelines indicate that it should not be used in children younger than age 4. And so, with that being said, a good rule of thumb is albuterol is probably the one that you'll see used more in practice, and it's probably a little bit safer as far as looking at the age range. Also, albuterol is the least expensive, and so when you're trying to consider these, of course, albuterol is usually the one that keeps coming to mind when you're considering what medication you're prescribing. Now, patient education is very, very important. When you have a condition such as asthma, patients need to be very versed in how to care for their condition and how to use the medication. So with respiratory system, asthma is huge as far as understanding as far as the treatment and also related to education. So make sure that you're looking at the education component for this section in your reading. For the MDI use, you need to demonstrate and also have the patient return demonstration. A lot of times you can provide a prescription for the inhaler and bring the patient back to your clinic and have the nurses do the education and also make sure the patient is using it correctly as a return demonstration. Now, check the correct inhaler use if patient says the inhaler isn't working. And so a good rule of thumb is to use a spacer with all patients. Now, breath-actuated inhalers require inspiratory drive to deliver medications to lungs. And so that's something that you also need to consider. So make sure that you know how to educate your patient as far as the correct use of inhaler, and you also need to consider using a spacer. So there's different instructions for your different subgroup of medications for this, and so make sure that you're taking a look at it. Now, some different things that you can talk to your patient about as regard to your adverse reactions is that the patient needs to be instructed not to exceed the recommended dosage of the medication, because excessive use, of course, increases the possibility that they will have adverse effects. And so if the patient is finding, one thing that I usually talk to my patients about is that if they are using this medication correctly, it should be, this many puffs per this many hours. And so if patients finding that they're having to use it more often, is usually a good indication that they need to really come back to your office pretty urgently, because this can be a sign of an exacerbation or worsening of their condition, and so they don't need to self-medicate by overusing the medication. And also, overusing the medication can increase the likelihood of adverse effects. Now, overuse of the beta-2 agonist bronchodilators can lead to seizures, hypokalemia, also angina, and also hypertension. And so they can also have stimulant-like effects, which includes increased heart rate and tremors when they begin the medication, but these should start to go away or lessen if they use it correctly. And they can also get a headache, so just let them know this up front. So if the patient is having issues or adverse reactions such as palpitations, tachycardia, chest pain, muscle tremors, dizziness, headache, or flushing, then they need to be letting you know. So the next thing we're going to talk about is xanthine derivatives. And so the two medications that we focus on is theophylline and caffeine. And so looking at the pharmacodynamics, you see a bronchial smooth muscle relaxation, CNS stimulants, cardiovascular effects, increased gastric acid production. It stimulates skeletal muscle, and it also increases renal blood flow and glomerular filtration rate. With pharmacokinetics, it's absorbed rapidly and completely from the GI tract. It's distributed widely, and the volume of distribution is altered in premature neonates, elderly patients, cirrhosis, pregnant women, and this is primarily in their third trimester, critically ill patients, and this is usually probably because of altered protein binding. It's metabolized extensively in the liver via the CYP450 into caffeine, and if you have disease states and CYP inducers, it can influence metabolism of theophylline, and it's eliminated renally. Precautions and contraindications for these medications. The only true contraindications to theophylline are hypersensitivity to xanthine, peptic ulcer disease, and any underlying seizure disorder. Contraindications to caffeine include hypersensitivity to caffeine and use of caffeine sodium benzoate formulation in neonates. Now, one thing about this class of medication, it does have effects on the cardiovascular system, and so if patients have hypertension, ischemic heart disease, coronary insufficiency, CHF, or history of stroke and cardiac arrhythmias, you have to really watch them more closely for adverse effects while taking theophylline. Excessive use can also lead to toxicity, and so with theophylline, the incidence of toxicity increases when serum theophylline levels are about 20, and so that's your area that you need to kind of look for. Toxicity is found if serum theophylline levels reach 25 micrograms per milliliter in 75% of patients. Now, toxicity should not occur at recommended dosage, but it may occur if theophylline clearance is decreased, and you can see that in conditions such as hepatic impairment, chronic lung disease, cardiac failure, patients older than age 55, and infants under age 1. And theophylline clearance may be decreased in patients over the age of 55. So you really have to monitor for theophylline toxicity, and so make sure you're looking at that because sometimes that may show up on boards. It's also theophylline is a pregnancy category C, and you have to really be more careful with monitoring in children and also in infants, and so be very, very careful with this. With adverse drug reactions, these are uncommon with serum theophylline levels below 20, and so you really need to know that magic number of 20. So make sure that you're looking at this. Some patients will have seizures at 15 to 20. You can see CNS effects such as irritability, restlessness, seizures, insomnia, GI effects such as reflux, worsening heartburn, cardiac effects, palpitations, tachycardia, hypotension, and life-threatening arrhythmias. And when you start seeing levels over 20, then you start seeing more toxic symptoms, and you have to know the signs and symptoms of this, and this includes nausea, vomiting, diarrhea, headache, insomnia, and irritability, and so make sure that you're aware of this. You also need to know toxicity for greater than 35, and this can include hyperglycemia, hypotension, cardiac arrhythmias, tachycardia, seizures, brain damage, and also death. And so make sure that you're knowing these two. With caffeine, adverse drug reactions include cardiac arrhythmias, tachycardia, insomnia, agitation, irritability, headache, nausea, vomiting, and also gastric irritation. Now, with theophylline, drug and food interactions, there are many drug interactions due to metabolism of the via CYP450 isoenzyme, CYP1A2, CYP2E1, and CYP3A4. So smoking tobacco increases clearance, and so you have to look at this if a patient increases or decreases or stops. So you may have to change around a little bit. Benzodiazepines are antagonized by theophylline. Beta agonists may cause additive toxicity. You can see reduced lithium levels, and when you're dealing with a carbohydrate and protein diet, you have to teach the patient regarding this and monitor this. A low carb, high protein diet increases clearance, and so you've got to be very cognizant of this. And a diet high in carbohydrates and low in protein decreases the elimination and lengthens the half-life of theophylline. Also, a diet that contains a lot of charcoal broiled foods, it accelerates the hepatic metabolism of theophylline because of the high polycyclic hydrocarbon content. And so that's something that you need to talk to the patient about. With caffeine, caffeine is metabolized via the CYP450 isoenzyme, CYP1A2, CYP2E1, and CYP3A34 substrate. And so other drugs metabolized via these isoenzymes will possibly interact. And so these can include cimetidine, ketoconazole, fluconazole, mexiletine, and also phenylprolamine may impair caffeine metabolism, and it can lead to increased serum levels. Caffeine elimination may be increased by co-administration of phenobarbital and phenytoin. Now, the clinical use and also the dosing. The National Heart, Lung, and Blood Institute expert panel provides guidelines for the management of asthma and recommends reserving theophylline for long-term control of asthma and an alternative, not preferred, therapy in step 2 of asthma care. So make sure you're looking at the expert panel report. It recommends using theophylline as an alternative treatment in combination with inhaled corticosteroids. Now, the guidelines recommend that long-acting beta-2 agonists, and this is in combination with inhaled corticosteroids, be tried before theophylline because of toxicity issues with theophylline. Theophylline is not recommended for first-line therapy in COPD, but if a patient's been stable on theophylline, there really is no reason to discontinue the medications as long as the serum theophylline levels are being monitored. And so don't just take them off of it if they're fine. So keep them on it and monitor it. Now, there's different dosages for theophylline. This is something that's just nice that you can take a look at. But, really, you really don't need to commit this to memory. Theophylline's not used primarily in the advanced practice setting. It's an alternative that can be used, but take a look at this and make sure that you're aware of this and you're dosing this according to a different formula, but you don't have to commit this to memory for testing purposes. Now, for apnea of prematurity, caffeine citrate, 10 to 20 micrograms per kilogram is given in the treatment for apnea of prematurity. The maintenance dose of 5 mg per kilogram per day. The theophylline dose treats apnea of prematurity, and the patient is given a loading dose of 4 mg per kilogram per dose. and the maintenance dose of 4 milligram per kilogram per day in the premature infant or newborn up to age 6 weeks. Now with theophylline, just looking at rational drug selection, theophylline is the only xanthine derivative that is commonly used in asthma and COPD, and so you're looking at different forms of theophylline based on cost and also convenience. So with immediate release, you use it at the beginning of therapy to determine daily dosing, so you're kind of testing the waters. And once a patient is stabilized on immediate release, there's a transition to extended release once the total 24-hour dose has been determined. With a timed release, there's a variety of different time release theophylline, and there's a table that you can take a look at. The formulas range from 8 to 24-hour release, and you have to take these daily at the same time. Now with monitoring, monitoring is a big factor for theophylline, and patients who is taking theophylline has to be monitored very carefully for signs of toxicity, and so you need to know the range that you can see symptoms. And so if the patient is demonstrating any signs of toxicity, you know, even if it's not due for them to have a serum theophylline per se, always draw a theophylline level. You also draw frequent levels when the dose is being titrated, and so when you're trying to get them to that therapeutic dose, you kind of want more control, and so you're more likely to draw the levels. Now after a steady state has been achieved, you draw levels every 6 to 12 months. And you also draw levels whenever a new medication is added or deleted for your regimen. And so, if all else, just draw a level just to make sure. So just be very careful with these, and if you've got a question, just draw a level. With patient education, the patient needs to take it exactly as prescribed. You also need to discuss signs and symptoms of toxicity and discuss this with them. Avoid large amounts of caffeine-containing beverages, and also explain to them the diet components with theophylline. Now, inhaled anticholinergics, Atrovent blocks the muscarinic cholinergic receptors, and also Spiriva, which inhibits the muscarinic M3 receptors in the legs, and both of these cause bronchial smooth muscle relaxation. Now with anticholinergics, under this, with precautions and contraindications, ibupropium is contraindicated with patients who have had hypersensitivity to atropine or atropine derivatives, and for those with bromide sensitivity. Tiotropium is has a contraindication patients with hypersensitivity to ibupropium or tiotropium. Now, the inhaled anticholinergic should not be used for the treatment of acute bronchial spasm. Now, the exception is if ibupropium is combined with albuterol in an emergency room treatment of acute bronchial spasm. Now, inhaled anticholinergics, even though poorly absorbed systemically, should be avoided for patients with urinary retention, bladder neck obstruction, or prostatic hypertrophy because of their anticholinergic effects. Ipratropium bromide is pregnancy category B, and tiotropium is pregnancy category C. They're really not approved for use in children, and the expert panel 3 guidelines state ibupropium may be used in children as an adjunct to beta agonist or albuterol therapy in acute exacerbations of asthma. Now, the anticholinergic drugs may increase intraocular pressure in patients with closed angle glaucoma, so this is also a consideration. With inhaled anticholinergics and looking at adverse drug reactions, cough is the most common that you've seen with ibupropium. Other symptoms can be hoarseness, throat irritation, and dysgeusia. And you can also see some GI effects, but it's mainly thought to be the anticholinergic effects as far as the GI system. Dry mouth can be seen, mild anticholinergic effects in a few patients, such with constipation, urinary retention, and you can also see headache and in some of the patients also. Now, you've got to be really careful about spraying in the eyes. The patient can have temporary eye irritation, pain, mydriasis, blurred vision, cycloplegia, irritant conjunctivitis, and visual disturbances. Also, a rare allergic and anaphylactoid reaction can occur, and reactions include urticaria, maculopapular rash, bronchial spasm, pruritus, laryngeal spasm, or pharyngeal edema, and angioedema of the tongue, lips, and face. And so the patient's history usually includes sensitivity to other drugs and foods, and patients with milk protein hypersensitivity should not be prescribed a cyclodimine bromide, so you've got to be very careful with that. With clinical use and dosing, COPD, it's commonly used with COPD, and these are the doses that you can see for these medications. Asthma, these are also the different doses that you can see for the treatment of asthma. Now with cost, combined albuterol ipratropium products are cheaper than the two individual drugs, and when you look at a comparison between the generic ibupropium albuterol nebulizer solution, it can be anywhere from $13 compared to the $200 for the other two medications, so that's a consideration you also have to keep in mind. Now with patient education, of course you need to discuss with them how to use the medications and not to exceed the dosage and to use exactly as prescribed. And you also need to educate on the use of the inhaler or the hand inhaler, and also rinse the mouth after inhaling the medication. Now, leukotriene modifiers are a medication that we've used over the past few years. We used to use it really widely, but we've backed off in later years. Now, with these, you have to kind of know what the leukotrienes do, and as far as knowing how this medication works. And leukotrienes are substances that induce numerous effects that contribute to the inflammatory process, including smooth muscle contractibility, neutrophil aggregation, degranulation, and chemotoxic vascular permeability, and lymphocytes. And there's two ones that are used, acrylate and Singulair. Now with the leukotriene modifier pharmacodynamics, what you can see with this is zircaloxate is a synthetic selective and competitive LTRA of leukotriene D4 and DE, and these leukotrienes have been identified as components of slow-reacting substance of anaphylaxis, and monoleucase is a selective LTRA that inhibits the cysteine leukotriene receptor. It binds with high affinity and selectivity to CystTL1 receptor. Also, monoleucase inhibits the actions of LTD4 at CystT1 receptor, and so there's also evidence that cysteine leukotrienes contribute to the pathophysiology of asthma and allergy, and this also includes airway edema, smooth muscle constriction, and cellular changes associated with the inflammatory process. Now, in vitro studies demonstrate that zircaloxate antagonizes the contractile activity of the three leukotrienes, and this is LTC4, LTD4, and LTE4, in the conducting airway smooth muscle, and monoleucase may also inhibit symptoms of allergic rhinitis, as leukotrienes are released from the nasal mucosa during allergen exposure. Now, when you're looking at precautions and contraindication, one of the things I need you to understand is that it is not used for primary treatment of acute asthma attacks, so it's not a monotherapy. And as we spoke before, monotherapy means just one. It's not monotherapy for acute asthma attack. It's just it's a tag along for asthma. Now, the only true contraindication is hypersensitivity to the components. Something that you also need to kind of remember is the chewable tablets are contraindication in patients with PKU because the product that contains phenylene, and so that you can see that with different medications, that if patients also have PKU, you've got to be very careful in the different medications that they're consuming. Xylitol is contraindicated with patients with active liver disease. Be very careful about using with hepatic dysfunction because it's extensively metabolized in the liver. And it should not be abruptly substituted for inhaled or oral steroids. And so you also need to use caution if systemic corticosteroids are used. And so be very cognizant of this. Contraindications, Zerferilcast and Montelukast, hypersensitive to any of the components of the medication. Chewable patients with PKU, and Xylitol with patients with active liver disease. Very, very careful with this. Adverse reactions, the most common one that you will see is headache. Don't really see that so much in my experience with the medication, but it's the most common one that can be reported. Less common is GI upset. I've seen some patients with myalgias, fever, and increase in respiratory infections, but overall this medication is pretty mild as far as adverse drug reactions. You don't really see this so much in comparison with some of the other medications that you can use. Now, leukotriene modifier clinical use and dosing. Zerferilcast, you can see it use, and this is an adjunct. This is adjunct medication for chronic asthma, and this is generally 5 years and up. Montelukast, persistent asthma, 12 months and up, and exercise-induced bronchial constrictions, 15 years plus. And Xylitol, persistent asthma, 12 years and plus. And so you've also got to be very careful when you're considering the use of this medication. This is also something important to remember is neuropsychiatric events. And so there was actually a problem with this. Neuropsychiatric events were reported in post-marketing studies with adult, adolescent, and pediatric patients taking leukotriene modifiers. And so the reported neuropsychiatric events were agitation, aggression, anxiousness, dream abnormalities, hallucination, depression, insomnia, irritability, restlessness, suicidal thinking and behavior, including suicide and tremor. And so you need to be judicious in the use of these medications, and you also need to be selective, and you need to educate the patients to notify them that these can happen before you prescribe it. And if they're experiencing any of these, is to notify you regarding these immediately. Now, with looking at your drug selection, you look at the age of the patient, and you also look at the formulation the patient needs. And because some of the younger patients, they may need more dosing as far as with their meals or chewable or just the age per se. And so there's a big price difference with these medications, and that's also a consideration that you have to consider. With monitoring of improving or worsening asthmatic symptoms, bronchodilator use and pulmonary function is necessary to determine how well these are working. And so you also need to Make sure that you're monitoring their pulmonary function and also new onset of neuropsychiatric symptoms. And so we talked about this before, and that's something that you have to monitor for, and also that's part of your education. And these are agitation, aggression, anxiousness, dream abnormalities and hallucination, depression, insomnia, irritability, restlessness, suicidal thinking and behavior, including suicide, and tremors. So make sure that you know this. Patient education, you need to educate to take as prescribed, do not take if pregnant or nursing. Watch for different drug interactions, and also watch for your neuropsychiatric events. With lifestyle management, self-monitor respiratory status with a peak flow meter. And so that's something also that when you're teaching patients about care of their asthmatic symptoms is how to use and evaluate any for exacerbations and stability with a peak flow meter. Avoid or quit smoking. Avoid environmental triggers for asthma at home, work, and school, and other symptoms associated with the disease process for which the medication is being treated. Now, there's some wonderful things that can be accomplished with corticosteroids, and we'll look primarily at inhaled corticosteroids. And some of the benefits that you can see are reduced severity of asthma, increased peak flow readings, decreased airway hyperresponsiveness, and it's safe and well tolerated at recommended dosages. Now, precautions, avoid if using for relief of acute bronchial spasm. And so patients need to be educated that this is not for acute bronchial spasm, it's more for maintenance. It's also sort of a substitute. It's better than using oral corticosteroids because oral corticosteroids have so many adverse drug reactions associated with these, and so you don't have the systemic effects as you do with oral corticosteroids. Now, you really need to be careful if the patient is experiencing Cushing's syndrome, pregnancy, herpes, tuberculosis, nasal trauma, or ulcers, and untreated respiratory infections. So these are considerations that you need to be aware of, and you need to have care for these with prescribing this for patients. With the corticosteroids, there's drug interactions, and there's known and unknown, and ritonavir increases fluticasone serum concentrations, and ketoconazole increases plasma concentration of fluticasone and also bucenide. The other, we kind of we don't know at this point. Now, inhaled corticosteroids are the preferred long-term control medications for managing the inflammatory process associated with asthma. And so what I do want you to do is I do want you to look at the step fashion for diagnosis and treatment of asthma, and you'll have to know that. You'll have to know that for your other classes, so make sure that you're taking a look at this. All patients with mild persistent asthma are started on a low dose of inhaled corticosteroids. And so make sure you're taking a look at this. It's based on how you control or treat asthma. It depends entirely on if they have a diagnosis of persistent, mild, moderate, or severe. So you have to look at that chart. You will have to know that chart. Allergic rhinitis, it's used to manage seasonal or perennial allergies, and you use this intranasally 1 to 2 times a day. Inhaled corticosteroids with monitoring. With this, patients using normal dose, you've got to monitor for adverse effects of the medication, effectiveness of the medication, the asthma disease process, and if patients are using for high dose for a long period of time, you need to do a blood glucose and potassium if a high dose is used for an extended period of time. Administration with inhaled, use spacers and rinse the mouth with water after each use, and intranasal, clear nasal passages of mucus before you use the medicine, so gently blow the nose before you use it, and also after each use, patients need to rinse with water to reduce the dry mouth hoarseness and also the risk for candidiasis infection. Adverse reactions includes xerostomia, hoarseness, tongue and mouth irritation, flushing, dysgeusia or altered taste sensation, and also dysmenorrhea. Less common adverse reactions include oral candidiasis, cataracts, bronchial spasm, HPA suppression. You see this more with your oral corticosteroids instead of your inhaled. But if you're using high doses for extended period of time, this is a possibility, especially. Pulmonary infiltrates with eosinophilia, nasal irritation, itching, sneezing, and dryness, and also bloody nasal mucus or epistaxis for your intranasal, and also you have the risk of polyps. Lifestyle management. Patients need to self-monitor the respiratory status, avoid or quit smoking, avoid environmental triggers for asthma at home, work, or school. Treatment for oxygen is necessary for life in diseases that interfere with normal oxygenation or blood and tissue. It's a basic element essential for human life. And with patients that do not have adequate amounts of it, it can lead to rapid death. It's a therapeutic gas, which is 99% pure, and it's prescribed to treat hypoxia or tissue deprivation of oxygen. Now, with precautions and contraindications, the only contraindication to oxygen use is concurrent smoking while the oxygen is running, and so this is a huge problem. You probably know patients that have been in a hospital setting or other settings that have forgotten, and they have they've been around open or live flame, or they've lit a cigarette up, and of course you've had some issues associated with that as far as explosion. It's a flammable gas and it will ignite, and so for patients, you have to make sure you educate them regarding this, and if they're a chronic smoker, they have to turn their oxygen off if they're smoking and not be in proximity to it, ideally. Now, oxygen should be prescribed to patients with chronic carbon dioxide retention with extreme caution and close monitoring. In these patients, hypoxemia can be the primary stimulus for respiration, and so the lowest possible concentration of oxygen is needed to avoid serious tissue hypoxia. And patients with hypercapnia, the sudden increases in PaCO2 produced by oxygen may result in cessation of respiration, so you've got to be really, really careful with this. Adverse drug reactions. The most common one that you will see is with oxygen administered nasally is dry nasal passages, and so you may need to add a humidifier to this, and so it can be prevented and managed. Toxicity can occur, and you can see it with inspired concentrations of oxygen exceed those of air for prolonged periods of time, and you can have cell membrane death and some serious issues related to this. It can occur by increased production of reactive species such as superoxide anion and singlet oxygen, hydroxyl radical, and hydrogen peroxide. And some of your tissues, such as your respiratory, CNS, and retina, are more sensitive to high oxygen concentration, so you've got to be very careful. So death can occur, and you've got to be careful with this. And in premature neonates, the retina can be damaged to high levels of oxygen for prolonged periods of time. With clinical use, it treats hypoxia, but it's not curative. And with the dosing, you look, oxygen is administered to treat hypoxia as determined by pulse ox or arterial or mixed venous blood gases. And hypoxia is usually a symptom of underlying disease. So oxygen is to treat symptoms. It doesn't cure it. It provides symptomatic and temporary improvement in the patient's status. Any underlying causes needed to be addressed. Now, with dosing goals, the goal of treatment is to maintain oxygen saturation above 90%, and there's various different delivery methods that you can use. You can use nasal cannula, mask, hoods, or tents, and you've got to also consider the patient's home situation and different factors when prescribing this. Monitoring methods, arterial or mixed venous blood gas sampling, and that helps you as far as determining treatment, and pulse ox. It measures the difference in absorption of light, and it measures hemoglobin saturation and not PO2. Now, things you need to consider working with a patient about is to avoid or quit smoking, and offer them smoking cessation aids if they're interested. Also discuss with them to avoid exposure to viral respiratory infections, high altitudes, and also contact you before they travel by air. Now, education is also key for home oxygen therapy, and then you need to talk to them about safe administration. You also need to talk with them about the use of oxygen and not to increase or decrease just when they decide they need to, because it can have adverse effects. And using oxygen for fewer hours than prescribed will increase hypoxia, and it can have some really serious effects. Also need to emphasize that oxygen is flammable, and it needs to be kept away from open flame. And so you have patients that are chronic smokers, and realistically, you're not going to keep them from smoking if they want to continue smoking, but you need to educate them to turn their oxygen off and avoid open flame while their oxygen is running because of the flammability, and it can they can have serious consequences related to this. Now, the next thing we're going to talk about is antihistamines, and there's a lot of different uses that we use antihistamines for. Reduces or prevents most physiological effects of histamine at the H1 receptor site, and strongly blocks the action of histamine and decreases the flare and itch response. Now, there's different generations for antihistamine, and the first generation is, we still widely use it. It's Benadryl, and the second generation is non-sedating antihistamine. And the good thing to the patients who use this is there's not the degree of drowsiness as you see with dihydramine. And but each of these have their own various different pros and cons with using in a comparison for first generation and also second generation. Now, first generation antihistamines, they're very widely available without prescription, and they're widely prescribed. And the thing about it is you really need to know the precautions and contraindications for these. They're generally safe and effective. They're contraindicated in patients with narrow angle glaucoma, lower respiratory tract symptoms because they really thicken up the sputum and secretions, stenosing peptic ulcer, symptomatic prostatic hypertrophy, bladder neck obstruction, and pleural duodenal obstruction, and also concurrent use of MAOIs. Now, there is a few, but there's some pretty significant precautions. Because of the anticholinergic effect, you've got to use caution with patients with a predisposition to urinary retention, history of bronchial asthma, increased ocular pressure, hyperthyroidism, cardiovascular disease, or hypertension. And your antihistamines can cause varying levels of sedation and drowsiness, and it can make people have reduced mental alertness. And so you've got to use caution. Patients have to use caution if they have to be mentally alert with certain things that they are doing. So that's something that you need to educate them about regarding this, and that is also for adults and also children. Now, the first generation antihistamines, usually several of these are pregnancy category B. Hydroxyzine and carbaminoxine are the only first generation antihistamines that are category C. First generation antihistamines are contraindicated in newborn and premature infants who may have severe reactions. Breastfeeding is also contraindicated because of the excretion into breast milk, and they may also decrease breast milk production. You also have to use caution with the use of first generation antihistamines in young children because they can have a paradoxical CNS stimulation, and you really don't need to exceed the recommended doses for this. Also, the first generation antihistamines are on the Beers criteria for your geriatric patients, so you've got to be very careful. Now, with the second generation antihistamines, the pregnancy categories are B and C. They're generally not recommended during pregnancy, especially the third trimester, because of the seizure risk to the fetus. So just need to be able to be aware of this. Fluoxetine below 6 years of age is not really recommended. Loratadine may be prescribed to children as young as age 2, and ceratazine syrup and loratadine syrup may be used in children as young as 6 months. First generation antihistamine adverse effects, you need to be aware of these. These include sedation or fatigue is huge, diplopia, dizziness, headache, tinnitus, lassitude, disturbed coordination, nausea, vomiting, irritability, nervousness, and also blurred vision. Now, you can also see diplopia or double vision, tremors, decreased appetite, epigastric distress, constipation, diarrhea, dry mouth, urinary retention, and also dysuria. Adverse effects for second generation include minimal incidence of dry mouth. Drowsiness is not noted as sharply as you would see for first generation, so you don't really see the drowsiness as you would see with first generation antihistamines. Symptoms, that if you have symptoms from first generation antihistamines, then if you switch them to a second generation antihistamine, a lot of times you won't see the drowsiness or some of the other adverse effects, so it usually makes a big difference with switching them. With clinical use, you treat respiratory allergies, hypersensitivity reactions, urticarica and angioedema, nighttime sleep aid. You see this a lot in your combination. If you find an over-the-counter sleep aid, a lot of times you'll see Benadryl use or dihydramine used with these. You can also treat for motion sickness and antiemetics. Lifestyle management, avoid known allergens. Sometimes you know it just by trial and error, and then sometimes if you have a allergy testing, a formal allergy testing, then you know these, and just avoiding these can help. Also use environmental methods to control dust mites and other common allergens. With dust mites, a lot of times if you use the mattress covers, wash your bedding in hot water once a week, and actually, environmental controls, that helps a whole lot. Decongestants, they're used for common cold, allergic rhinitis, and there's a lot of different methods that you can use. Liquid, tablet, capsule, nasal spray, and also drops. So there's a lot of different methods that you can use for these. Contraindications with these, there are only a few absolute contraindications to taking these. The oral decongestants are absolutely contraindicated for patients on concurrent MAOI therapy. Concurrent use of these medications can result in severe headache, hypertension, and hyperpyrexia, and possibly hypertensive crisis. And oral decongestants are also contraindicated for patients with severe hypertension or coronary artery disease. Now, the safety and efficacy of decongestants medications have been questioned, and so an FDA panel has recommended that all pediatric cough and cold medicines be relabeled as not indicated for children under the age of 4. So you need to be very aware of this, and so it is age 4. And so, latter years, manufacturers have removed all infant drop formulas of cough and cold medicines from the market, and the decongestants were relabeled. And so that is something that you've got to be aware of, because when you're out in practice, you may see patients still being prescribed these preparations, and so but you've got to be aware of this because you're responsible for your own practice. Adverse effects, more common ones that you will see are restlessness and tremors. Ones that you don't really see so much, they're not common or they're rare, are transient hypertension, arrhythmia, and cardiovascular collapse with hypotension. Adverse effects include transient stinging, and this is with a topical. Transient stinging, burning, sneezing, dryness, local irritation, and also rebound congestion with prolonged use. And so you really need to kind of know that. Now for the oral decongestants, it temporarily relieves nasal congestion, and it promotes nasal or sinus drainage and relieves eustachian tube congestion. Topical decongestant symptomatically relieves nasal congestion and relieves ear blockage and pressure pain. Now looking at the short versus the long term. Now the short, there are various short and long acting forms of both of your oral and topical. The short acting are better tolerated and have fewer adverse effects. However, the longer acting forms are used for patients who require all day or all night relief if the patients can tolerate them. With topical decongestants with adverse reactions, you can see insomnia, dizziness, tremor, weakness, or irregular heartbeat. With higher doses, you can see nervousness, dizziness, or sleeplessness. Now with decongestants, lifestyle management includes maintaining adequate hydration, refrain from smoking when congested, and also avoid caffeine-containing products. Antitussives are something that we use quite frequently across the different APRN settings. Patients use this to self-treat coughs, and so it's really important to educate the patient on the useful mechanism a cough provides by clearing the airway of secretions and oral material. Now, a cough should not be suppressed if protecting the airway. And so there's times, though, that an antitussive is necessary to provide rest or sleep. So you've got to be able to kind of think about it because a cough reflex can be very protective. And it involves the CNS and peripheral nervous system and also the smooth muscle or the bronchial tree. So you've got to be able to think about also the different types of drugs that can affect the mechanism. It can be from bronchodilators or drugs that act centrally or peripheral to suppress cough. And so what we talk about here is the antitussives such as dexamorphan and benzoate. The other cough suppressants, such as codeine, is covered in different sections. Now, with precautions and contraindications, patients do not need to use for persistent or chronic cough caused by smoking, asthma, or emphysema. Also, if They really don't need an antitussive if they are having excessive respiratory secretions, and they do not need to self-medicate cough for longer than 7 days. Benzenate is contraindicated for patients allergic to tetracaine, procaine, or related compounds. Dexamorphine, codeine, or benzenate can cause drowsiness, dizziness, nausea, and also GI upset. If patients are taking benzenate, they can also experience headache, constipation, pruritus, skin eruptions, and a sensation of burning eyes or a vague chilly sensation, chest numbness, and hypersensitivity. Now, if patients have a hepatic function impairment, they should be monitored if dexamorphine is prescribed because the metabolism of the drug may be impaired. Metabolism of codeine can be affected by deficiency of 450D or by medications who inhibit CYP2D6. Now, codeine can cause dependence, and you need to be really careful in patients with a history of substance abuse. There has been some abuse of dexamorphine containing products, especially among teenagers, and so you have to be very careful of this, and dexamorphine is being looked at as far as should it become a scheduled drug or not. And some settings, you have to be a certain age before it can be dispensed. Codeine can cause decreased gastric motility and should be used cautiously in patients with GI obstruction, ileus, or pre-existing constipation. And patients with acute ulcerative colitis may be sensitive to the constipating effects of codeine. Dexamorphine and codeine are pregnancy category C. Lifestyle management. Patients need to increase fluid intake, refrain from or quit smoking, and they also need to avoid respiratory irritants in people with respiratory infections. Now, expirants such as guaifenesin is the only expirant ingredient listed by the FDA as having scientific evidence of safety and efficacy, and it aids in symptomatic treatment of cough due to common cold and mild upper respiratory infections, and so it's really helpful with a lot of respiratory tract secretions. Now, precautions. It shouldn't be used for persistent cough such as smoking, asthma, or emphysema. Cough related to heart failure or ACE inhibitors should not be treated with guaifenesin, and a cough accompanied by a high fever or lasting longer than 7 days need to be evaluated. Guaifenesin is pregnancy category C. There's been no problems in breastfeeding women with taking the medicine, and use in children as young as age 2 is considered safe. And actually, I've seen guaifenesin used in fertility for patients to thin out their cervical mucus. Adverse drug effects, and the most common that you can see are GI upset, nausea, and vomiting, and less common are drowsiness, diarrhea, dizziness, rash, and headache. But generally, I don't really see patients having a lot of adverse drug effects with this medication. Now, there are no drug interactions of significance with the use of this drug, but it can cause some false readings in certain labs, and so patients need to make sure that if you're using this medication, that they are listing guaifenesin as one of the medications they are taking if they do a drug test. Now, for uses, it's for a dry, non-productive cough with mucus in the respiratory tract. It works best if you've got a cough you've got chest congestion and you need that mucus thinned out so you can get it out, you can get it up. As far as management of lifestyle, patients need to remain well hydrated. Patients do much better as far as allowing the medicine to work if they have adequate fluids, and so a lot of times I'll encourage them to make sure that they're drinking adequate fluids because it will help this medication work more properly. And patients also need to refrain from smoking. This is the end of this presentation.